Hi, in this video we will learn about the tracheoesophageal fistula. Tracheoesophageal fistula is an abnormal communication between the trachea and the esophagus, and it can be of two types, congenital and acquired. Now before we understand this, let us look at the embryology of the development of the respiratory system. So at around 4 weeks of intrauterine life, the foregut tube gives rise to a respiratory diverticulum. The formation of this respiratory diverticulum is induced by the transcription factor TBX4. Now TBX4 is produced by retinoic acid produced by the surrounding mesoderm. So the surrounding mesoderm will produce retinoic acid, which will produce transcription factor TBX4, which induces the formation of respiratory bud and continued growth and differentiation. So the entire respiratory tract is endodermal in origin because the foregut tube is endodermal. However, the cartilage, muscles and connective tissue is formed by the surrounding splanchnic mesoderm and therefore is mesodermal in origin. Now once formed, the respiratory bud starts growing caudally. So let us look at this through a transverse section. Now when it starts growing caudally, two ridges start developing longitudinally. This is known as your tracheoesophageal ridge. The tracheoesophageal ridge ultimately joins together throughout the length of this foregut tube to form a septum, which then leads to the formation of a dorsal esophagus and a ventral trachea. So any abnormality in the development of this tracheoesophageal ridge or its joining to form a septum will lead to abnormal communication between the esophagus and trachea and ultimately lead to tracheoesophageal fistula. However, this is also associated with other congenital abnormalities which is labeled as vector L. V for vertebral anomalies, A for anal atresia, C for cardiac defects, T for tracheoesophageal fistula, E for esophageal atresia, R for renal anomalies, and L for limb defects. So whenever we get a case with congenital tracheoesophageal fistula, we always need to rule these malformations as well. So in a child, look out for tracheoesophageal fistula with esophageal atresia, cardiac anomalies, vertebral anomalies, anal atresia, renal anomalies, and limb defects, which is vector L. The acquired tracheoesophageal fistula can be of two further types. Either it can be due to non-malignant causes or it can be due to any malignancies. So the non-malignant causes include trauma, endotracheal tube intubation. In this, there can be pressure necrosis of the tracheal wall which leads to tracheoesophageal fistula, and TB. Whereas in malignant causes, the most common cause is esophageal carcinoma. There can be tracheal carcinoma, malignancies of the lungs, or any metastatic lymph nodes, which erodes into the trachea and the esophagus, giving rise to the fistula. Now let us look at the classification of congenital tracheoesophageal fistula. We have 5 types of congenital tracheoesophageal fistula labeled from A to E. In type A, the esophagus is atretic and there is no connection between the trachea and the esophagus. 10% of tracheoesophageal fistula are of A type. In type B, the proximal part has a fistula whereas the distal part is atretic. Less than 1% of the cases of tracheoesophageal fistula are of B type. In type C, the proximal portion is atretic whereas the distal portion has the fistula, and this is the most common type, accounting for 85% of the cases of tracheoesophageal fistula. And in type D, both proximal and distal portion are present with fistula, Less than 1% of the cases present as type D. In type E, which is also known as the H type, there is a single communication between the esophagus and the trachea, and the esophagus is not atretic. So one way that I remember this classification is, if A is considered 0, as there is no connection between the trachea and the esophagus, and type E is considered 1, as there is one connection between the trachea and the esophagus, then type B will become up as the upper portion is connected, type C is down as the lower portion is connected, and type D is up plus down as both the portions are connected to the trachea. So it is 0, up plus down, and 1. Now since down is the most common cause, our further discussion will take place taking C as the standard. Now let us look at the presentation of tracheoesophageal fistula. So the congenital variety can present prenatally as polyhydramnios. This is because the proximal portion is atretic, and hence the fetus is not able to swallow the amniotic fluid. Now at birth, again, since the fetus is not able to swallow, they present with copious white frothy mucus and saliva in the mouth and nose, which recurs despite suctioning. Now since the distal portion has the fistula, aspiration of contents of the stomach can lead to coughing, choking. Now this is associated with cyanosis, and it is worse during feeding, and it can also lead to complications of the lung such as aspiration pneumonitis, lung abscess, acute lung injury, ARDS, bronchiectasis, etc. So when we look at the features, we tend to look at the features due to the atresia and due to the fistula. So the atretic segment presents with features due to inability of passage of saliva, and the fistulous portion presents due to the aspiration of the contents. Now when we come to acquired tracheoesophageal fistula, they will present with all the features of the congenital tracheoesophageal fistula except polyhydramnios and copious frothy saliva, as there is no atresia. The diagnosis of tracheoesophageal fistula can either take place prenatally in case of congenital tracheoesophageal fistula or postnatally in congenital tracheoesophageal fistula and also in acquired tracheoesophageal fistula. Features seen prenatally are polyhydramnios. An ultrasonography shows the absence of fluid-filled stomach and small abdomen. Postnatally, we can diagnose tracheoesophageal fistula using contrast study, but contrast study is associated with increased risk of aspiration pneumonitis and hence not preferred. Chest X-ray can also be done, in which the absence of gastric bubble is seen in atresia, and also when an nasogastric tube is introduced, it will show coiling in the mediastinum seen in atresia. Other method can be direct visualization of the fistula under combined flexible tracheoesophagoscope. In congenital tracheoesophageal fistula, the examination is not complete unless you rule out other congenital malformations, which is the factor L. Now let us understand the management of congenital tracheoesophageal fistula. For the management, we tend to follow the Waterson's criteria, which takes into account the body weight of the baby as well as the presence or absence of pneumonia. And on this basis, there is division into 3 classes A, B and C. Group A are babies with weight more than 2.5 kg and with no pneumonia. So immediate surgery is undertaken for such babies. In type B, the weight ranges from 1.8 to 2.5 kg and there may or may not be the presence of pneumonia. In this, first the child is stabilized and then surgery is undertaken. In type C, the weight of the baby is less than 1.8 kg or there is the presence of severe pneumonia, and in this, staged repair is undertaken with a gastrostomy for temporary feeding, along with antibiotics to control the infection. So the procedure which is undertaken is known as Cameron Height surgery. In this, first the fistulous tract is excised, second trachea is sutured, and third the ends of the esophagus are anastomosed. However, this type of surgery can only be done in type B, C, D and E. In type A, if the segments are close enough, then anastomosis of the ends can be done. However, if the segments are far apart, then we need to wait for the child to grow. Until then, gastrostomy is used for nutrition. Approach is the posterior right thoracotomy. And so the position of the patient is in the left lateral decubitus with the head end lifted to prevent reflux. So the complications of the surgery are: 1. There can be anastomotic leak, and that is why on the 7th post-operative day, contrast swallow radiography is done, and if leak is absent, oral feeds can be initiated. There can be stenosis or stricture, and that is why on the 3rd week after surgery, esophagus is dilated up to 24 French size to prevent esophageal stenosis. Other complications include pneumonia, atelectasis, and there can be recurrence of tracheoesophageal fistula. In acquired tracheoesophageal fistula, if it is of the non-malignant variety, then surgical repair is undertaken. However, if it is of the malignant variety, then the treatment is individualized and is usually palliative with self-expanding metallic stents or esophageal bypass. All this is done in a bid to prevent aspiration and the leakage of esophageal contents and its further complications. Thank you so much for watching. I hope you enjoyed the lecture. If you did, please like, comment, share, subscribe for more such videos.